Okay, let's start the second session of this day. I wish you to all good morning, or actually good afternoon. Kalimera, Karomai Povriskomaik Sanedo. I hope you understood what I told. So my beautiful Greek journey started many years ago, and I think I have been to Greek islands much more than an average Greek person. I'm originally from Croatia, but living just temporarily 32 years already in Finland. So I've been to Crete about 15 times and to 25 other Greek islands, and I discovered Marilia in Vienna like 3 years ago. And we discovered that we have the same grandmother, Apollonia from Karpathos. That was my favorite island in Greece. Okay, just let's go now to our very, very serious things. So I'm working as an obstetrician and fetal medicine specialist professor at University Hospital in Helsinki. And I'm proud to say that we are one of the countries with the lowest cesarean section rate. Our national rate is 17%, 17%. With almost the lowest maternal and neonatal mortality and stillbirth rate, and organization of obstetrics is very nice, and we have quite easy way to work there, and the rate of litigation or how we do with that is very easy. So if you are not satisfied with Greece, please welcome to Finland. Okay, so the first. And she's very, I guess, anxious or very eager to present this. I have honor to present Dr. Helena Bartels from Dublin University Hospital. She is just about to finish her PhD about the psychological impact of PAS on women and probably their family. Is it going to be post-traumatic stress disorder because those women think I'm going to die on the operation? Is it because they will think that I will lose my uterus, or in most of the cases they will get a premature baby? So I think maybe in the world there is no better person to tell us about psychological impacts on PAS to women than Helen is. Helen, good morning, good afternoon, good morning in Dublin, and please, the stage is yours.
And that's great. Thank you so much for the lovely introduction. So as Rajan said, I'm Helena. I'm presenting from Dublin on a topic that's very close to my heart and that I have a lot of passion for, which is the lived experience of mums and their families that are impacted by this condition. And in the next 20 minutes or so, like obviously I could talk about this for hours, so I'm going to try to condense it as much as I can. But really, I want to talk about what do we really know about this topic so far? What are some of the recurrent themes that we're seeing from studies from different countries? And really, most importantly, what can we actually do to help mums and families that are in this situation? So one of the first studies that ever looked at this was from Sally's group, and it was very simple. They really just looked at women that were diagnosed with PAS versus women that had, massive hemorrhage, or that came to the clinic with to rule out Accreta, to see, what was the rates of PTSD in this population. And actually, they found there was a massive rate of almost 40% of women meeting criteria for PTSD after a diagnosis of PAS, which is equivalent to having, a serious psychological scarring from such as an assault or an RTA. So it's very significant. And we did a study then. We had around 140 patients partake in this, where we were looking at physical and mental health scores. And the graph on the right is really just to show you that the grey scores are the mental health domains. And this showed us that even though women's physical health was improving over the years after the pregnancy, actually their mental health remained low despite the improvements in physical health. And we also didn't find that there was any difference by pregnancy outcome. So mental health scores were equally low in women that had a hysterectomy or didn't, or that had an early baby or didn't. So it was really a universal experience for these Accreta mums. And then Brett Einerson's group in the US found very similar results, that women that were having a complicated cesarean for other reasons, so they had 3 sections, they had previa, compared to Accreta mums, months and years after the pregnancy, it was the Accreta group that had much lower mental health scores across domains such as grief and depression, anxiety and worry. And that was regardless of really having had more complexity from a surgical point of view. So this really highlighted to us there's work to be done and we need to explore this in more depth. And the way that we did that was through an interview study, which was an IPA approach. So that's an interpretive phenomenological analysis. So that means that you're really trying to understand how did a group of people make sense of their world after being diagnosed or having something happen to them, which in this case was accreta. And we included both mums, but also their support partners, which in this study was all fathers. And that's really important because obviously, as we know, pregnancy and birth doesn't just impact the mum, but actually the much wider family as well. And we divided this, like it became very apparent when we were doing these interviews. Some of these couples were in the first year after the birth, some of them were in 2 or 3 years afterwards. It became very apparent that there was really these 2 time points of living with accreta. So you have the diagnosis, you're pregnant, and then you give birth. And then this much more prolonged period afterwards of living beyond placenta accreta spectrum. And I want to highlight some of the key themes to kind of illustrate the stories that we were told through the mums and fathers quotes. And I don't have time to go through all of these themes, but the important part of the antenatal journey was that we found it was very emotionally traumatizing for these mums and very frightening. But they were able to cope quite well because they went into this kind of survival mode where their focus was on their baby, having a healthy baby, and really they were able to almost distract themselves from the emotional worry that they were feeling. And, these quotes from these parents kind of illustrate how scary that was. These mums saying, I jeopardized myself and my safety, my children's future, not knowing whether you're going to make it. It's very serious when they're diagnosed with this. Like, we have to tell them all of the risks. And even though thankfully, mortality and severe morbidity is becoming more rare, it's still very important that we're transparent with these couples. And no matter what you tell them, they will go off and Google and find these scary things. This father was saying it's a roller coaster of emotions. There was this real sentiment of that this should be such a joyous time. This was so unanticipated and shocking. And all of these women had a risk factor of a cesarean section, and not a single couple had heard about this condition before. And many couples had very different experiences of their antenatal care. For some who were looked after by a specialist team, they felt really well cared for. This father is saying everything was so well planned, they were looked after so well. Versus this mum who was saying, I was like a ticking time bomb. There's no continuity, there's no plan. And this was particularly the case where patients felt they were, referred somewhere for a scan, didn't really know what the follow-up was there. Were still in their local hospital who were telling them, well, we're not going to be looking after you. And really this, as you can imagine, creating huge anxiety and stress for these families. And this is really the sentiment of that theme of the survival mode, that even though it's very frightening and they're fiercely worried about their life, they're able to kind of have, I always call it, they have their eyes on the prize, they're focused on their baby and their birth and distracting themselves. This mum is saying, I was hoping that it actually wasn't accreta because they said they wasn't 100% sure. And that's what we've heard from this conference today. Like, we can't really be sure until we make the diagnosis at the time of the birth. And some mums and families, they really cling on to that. They're kind of thinking, okay, well, maybe actually on the day they'll tell me that everything is fine. And, it's that distraction, that coping mechanism. And again, this mum is saying, I didn't want to be defined by this and have my whole pregnancy defined by this. So you're kind of just trying to keep going like you're in survival mode. And then when it came to the day of the birth, there was this huge change in that it was a massively traumatic experience for both mums and the partners. For the mums, they felt hugely, traumatized. This mum is saying it was more traumatic than I ever thought. My first section was just a normal one, it's going to be straightforward. And, this mum was awake for the birth, but feeling she's too traumatized to even interact with her baby, even though, the team were thinking it was great that she got to be awake for it. And again, the father, saying, she didn't see her near-death experience. They're seeing all this blood, they're seeing all this, the staff around. It might have even been clinically not necessarily a very dramatic case, but for the partner and their own perspective. And that's one of the things that came out in the recommendations, is that we found, because mums with this condition, they almost always have other children. So usually the partner is at home minding them and not always able to come with them to all the appointments. So we had a huge amount of partners that were coming for the first time into the hospital at the day of the birth. They had no idea what was going on, were completely blindsided and incredibly traumatized by that. And then when we go into the postnatal period, we found that those first few weeks were very much dominated by relief of having survived. trying to focus with the serious physical morbidity that they experienced, which may be a midline laparotomy, they could have had a bladder injury, they could have had a hysterectomy, focusing on their newborn baby, which in some cases for some of these mums was in the unit. And then we kind of found this prolonged mental health impact on these mums, and I'll illustrate that a little bit through a couple of themes. So the first one that's really important is this living with a different body. They undergo this hugely traumatizing experience, but they're quite physically changed because of, some of the things that you've heard this morning about what happens to some of these mums. And you can see from these quotes that this really impacts women so much more than just the physical part of, oh, I don't have a uterus anymore, or I have this big scar. But actually women feel huge psychosexual consequences as a result of this. This woman is saying it's affected how I feel about myself as a woman. This other lady is saying, I have zero libido, I look disfigured. And obviously that's a huge barrier to returning to sexual intimacy and feeling good about yourself as a person, which is really, really important part of recovery. And this, living in this different body was such a significant thing for so many of these mums. And, this last quote from this mum is really that sentiment of what I was saying about that they go into this survival mode. They'll do whatever you tell them to do because they just want to survive. They just want their baby to be okay. They just want to go home to their families again. But then actually this mum is saying in the aftermath of all of that, it's actually not as easy as you think it will be, because at the time it's necessary to save your life and save your baby. But actually then you're left with this hugely altered body and emotional state that really was very unanticipated and mums were very unprepared for. And this had wider reaching impact on people's relationships. We found that the dads were very much, so worried, full of fear during the pregnancy, that when the woman then survived the birth and the moment the baby were at home, they were like, okay, that's it. We didn't want to talk about this. We need to move on. I'm glad this is done and it's over. Whereas for mums, because they were in that survival mode during the pregnancy, they never really processed or thought about any of that emotional trauma that was happening to them during the pregnancy. Then they have this really traumatic birth. Those first few weeks are about relief and survival, getting back to know their other children, looking after their newborn baby. And it's not until months later that they actually start to think about what's actually happened to them and are wanting to have conversations with people about that. But by that point, everybody else has moved on. So we found couples, the mums were really, really isolated. So, this mum is saying, people expect you to just forget everything. Seeing your baby, saying it's all worth it. Once you're home, people think you're grand. I'm still going through this now. And saying, she wouldn't even be able to have a conversation with her partner with it because he was so traumatized at the time and has just had to move on. And again, the partners, having that very opposite experience of, it was really terrible what happened, but we need to move on from this now. And, he's kind of feeling she was carrying the trauma around. It threatened us because she wasn't coming to terms with it. So we see this real difference in their mental and physical recovery during and after the pregnancy. And also with other children. This mum is saying, it changed my relationship with my daughter because I wasn't there. And this wasn't a lady that was admitted to hospital. This was a lady who was at home. But she said, mentally, I just wasn't present. I wasn't able to be there to my children because it was just this constant fear that you're just trying to get through every minute and you're really not present with your other children. So she found this was hugely impactful when she came home then after the birth with her other child and realised, how much time she'd missed with her daughter because of the experience. And a really important part of the postnatal period, and I think this is something that's universal to pregnancy, we have this very structured antenatal care where people come every couple of weeks, they know who's looking after them, they can ask people for questions, for help. And then after the birth, all of this just falls apart. And that was a huge theme. And as you've heard me say, it's the mental health things that only come months and years later. I always speak about the milestones as being the 6 months and the baby's first birthday. The first birthday often brings them back to what was happening this time last year and can be quite a struggle for them actually, to not think of it as, so many mums tell me it's the day of the surgery rather than their baby's birthday. And when they needed all this help and support, they'd had a 6-week check with the hospital and that was it, when it's purely just relief of being alive, having, still dealing with the physical consequences of all of this, whereas actually none of this mental processing had happened yet. So it's not surprising that one of the main things that couples told us were, we were so alone and so isolated when we needed help. And, the sentiment of this mum saying, the care just fell apart after the birth. where this father is saying it's not like having someone who's given birth, it's like having a sick person at home, because it is so different. And, you know, really saying we needed so much more follow-up and so much more help during this time. And these themes are really resonated in research from other countries, you know, so I've picked out the study from Sally from the UK group, and, you know, from Brett Arneson's group in the UK. And really, this challenge with the follow-up was really something that we found was very universal, in that, you know, this mum saying to go from amazing care to no contact with people who understand just resulted in me shutting it all out too soon. And this whole theme of living beyond paths, it's not over for these families when they go home. Like, for so many of these mums, their recovery is only just starting. And again, this wasn't just what we found, but what other people have described as well. You know, people don't recognise what I have lost as I have my son. That's just, it's so powerful, because that's what so many mums say. And it's not that they don't want to move on, it's just that they never had the opportunity to speak about it, because during the pregnancy it's too frightening. They just want to focus on their baby. And, you know, then immediately afterwards, everybody, their family, their partner, their friends see, oh, you know, you look fine now and you have your baby. So people don't think to ask. So they never have an outlet. But it's a very emotional time for them. So they really need so much more support. And very briefly, I just want to mention something that came out of our research was really that there was a huge variation in the experience of anaesthesia. So some mums found it horrifying that they were awake for the birth and found this so traumatizing. Like that mum was saying, I couldn't even interact with my baby, I was so afraid. Other mums felt, you know, this was my last pregnancy, I had a hysterectomy and I was robbed of the chance to see my baby be born, and, you know, that was so horrifying for me. So we felt we really had to maybe tease that out a little bit more and see what some of the common themes were. So we did that through a descriptive survey study, and we had around 350 mums partake. And we found that actually most mums do want to be awake, but it only happened for around 60% of them. But the key thing was really that women wanted to be heard and listened to, and have what the experience would be like explained to them. So you can see, you know, this first mum is saying she wanted her medical team wanted her to be awake, but she wanted to be asleep, and she really expressed a lot of concern about anxiety and PTSD, and that they respected her wishes and would let her be asleep for the whole thing. Versus this other mum who's saying, you know, I wish I could have been there to see the birth of my last child. It was very hard emotionally to miss that. I felt this delayed my bonding. And, you know, that's clearly a mum that really hasn't been, you know, counselled or explained about this, or, you know, maybe talked through what the whole care and case would be like, what the different options would be. And really, that was such a key thing that we found from this anaesthesia, that people that were well informed, regardless if they were asleep or awake, those were the people that had a good outcome, versus mums that really didn't feel that they were listened to, or that they had no choice in the matter. You know, one of the mums was telling us that, you know, she'd always planned to be asleep, but then on the day of the surgery someone said to her, oh yeah, but there's a high risk that your baby could die if you do that. And then she was awake and it was horrible. And obviously that's not true at all. So, you know, there was a huge variation in that kind of care. And we also explored postnatal pain management in this, because another thing that came out of our first study was that a lot of women felt that they were cared for as if they'd had a standard cesarean section, which obviously all of you know is completely not the case. So we wanted to tease that out a little bit more. And again, you can see from these quotes, you know, that so many of these mums felt, you know, we were being looked after as if we were a standard C-section. There was no understanding of why I was in so much pain. And, you know, this mum saying the pain is something I will always be traumatised by, which is terrible, because we know that poor pain management is a risk factor for developing PTSD later. Versus this lady who was looked after by a specialist team and felt that her team did everything they could to provide her with as good pain relief as possible. So very briefly, just to finish, I suppose, what can we do to help these families? And actually, there's loads of things that we can do. So many of these things, like I won't have time to go through them all, but you're welcome to read them and look up our work. But it's such simple things, like the things that these couples were asking for. I always call it low-hanging fruit. You know, it's not fancy special things that cost a lot of money. It's just having, you know, like specialist MDT care. I always put that at the top, because that's what we need to get mums through this safely from a surgical medical point of view. But also that's what these mums want in terms of their care, because they know that that's going to be the best outcome for them and their baby. we have to be clear about the diagnosis, how they're going to be monitored, investigated, what's going to happen in an emergency, what's going to happen in an elective case, and then that follow-up, that's so important. You cannot be discharging these mums and families at 6 weeks, and if you are, that at a minimum they have to have some kind of a way to get back in touch with your service, that they're not just completely alone and abandoned and maybe being looked after by their family doctor a year later, who really won't understand this, and we can't expect them to understand it because it's so rare. We need to provide information. We've done a lot of work in that area, but so have lots of other groups. We have leaflets that we give them now, we have a website, we have a podcast, and all of these things that they can feel more informed and, really educate themselves, as well as you explaining all of these things to them. And that continuity of the care provider is such an important thing. One person that's guiding them through the journey, that's a very trauma-informed care pathway from other fields as well. That having someone there that they know, who's there during the pregnancy, is there on the day of the birth, and that's the person that follows them postnatally, is just so empowering for these families, because there's someone that they don't need to explain again and again, but somebody who knows this. And then, as standard, referring them for psychological counselling or perinatal mental health, whatever is the available service locally. And other things like their physical care, like the mums were telling us, the physiotherapist came to see us on the first day of the surgery. When we were in a lot of pain, we, had an anaesthetic, our babies are in the unit, you're not ready to take in that information. So now we always get our physiotherapist to see them during the pregnancy, so they can prepare them for the physical challenges of the birth, start doing exercises with them. And the mums, it's super empowering for them as well, because they are a bit out of control and don't have that much say in what's able to happen. So this is something that they really feel very empowered, that they can do their exercises, do their physio, and really prepare themselves physically for the birth. And then obviously education for the rest of the team in the hospital. That's super important. Like, obviously we're experts looking after these mums, but actually they're going to be interacting with people in the antenatal clinic, with the physiotherapist, on the postnatal ward with midwives, and those people need to understand about this condition as well. They don't need to know everything in the way that we do, but they need to know that this isn't a standard cesarean section, and that's really important. And similar for the anaesthesia thing, they need to meet an anaesthetist during the pregnancy. They need to have a consultation around that. They need to have a post-operative pain plan that's going to be implemented, that women are reassured that will happen, but also that this is just standard things that are happening as part of PAS care, so that it's not just the birth happens and then, as one woman said, once my baby was delivered, my well-being was an afterthought, but actually that we continue this really good evidence-based MDT care into that postnatal period. And that really does involve our anaesthetist at every step, especially with the postnatal pain piece. And this is a decision aid that we came up with really to try and provide mums with information that they can think about what are the risks and benefits of some of the types of anaesthesia. Why is one safer for me, or is there no difference for me? And really that they feel a little bit more informed and empowered going into that surgery, rather than just feeling, I've been told this is the only option for me. And even there might be particular mums that one option is by far the safest for medical reasons, and an explanation of that will help mums to understand and cope with this in the postnatal period, rather than looking back and thinking, oh, maybe I should have been awake, or maybe I should have been asleep. Whereas understanding, like, knowledge is power. And just very briefly to finish, this is our patient group, Centre Crete Ireland. We do lots of work with mums and families to support them and advocate with them. And, as I said, these families can feel so isolated and alone and really feel that they have nowhere to turn to. So a support group and peer-to-peer support can be a really powerful part of that. But also the resources that we've created, like I mentioned, our website and some of our videos and our podcast, which is really, listening to the spoken words of other mums, is something that can be really help these mums to feel less alone in an experience that, no matter how much we support them, it is very different to speak to another mum that's actually had this, or listen to the voice of someone that's been through this. So I really would recommend, if you have your own resources, or, you can refer them to ours, or we're always willing to work with other people. But I think you'll really find this is something that can support mums hugely, because we obviously can't be there all the time, but these are things that can really support them when they're having low times. And my last take-home messages would really be, remember that, yes, this is, a scary medical condition and it's surgically challenging. And of course, we want to be doing all of our fancy imaging and get the intraoperative diagnosis right. And that's all super important, and mums really care about that. But also, don't forget that this is a person and a family who's going through a really emotionally challenging time, and we have to integrate these support measures from our own team, from our physios, from our perinatal mental health into our teams. And it's not over for them when they go home, so don't forget about them at that time. Keep an open dialogue of communication. Maybe you don't have the facility to bring them back at 6 months or a year, but at least that they have a number that they can call, that they can come back, rather than getting lost in the world out with, their family doctors who maybe don't know where to direct them. And if you're looking for improvements in your service and you're not sure what the areas are that you need help with, ask the people that have come through them. That's really such a powerful thing. If you're wondering, well, I think we're doing this well, but maybe we need help there, just ask the families that have been through and they will tell you. And it's a very rewarding way to improve things. So thank you so much. And I suppose I want to leave you with this quote from this mum, which, I've said that it's very challenging time, but a huge amount of these mums go through post-traumatic growth and actually are very strong and empowered and feel that, this mum is saying, I'm very grateful now for my life and for my baby. And so it's not all bad for these mums either. So thank you so much. And I'm happy to take any questions online.
Now we have a small change in the order of the presentations because some people have to leave to the airport, and the next next speaker is Dr. Olivier Morel from Nancy in France. Is it true?
Yeah.
Yeah, he's our great friend, and we know for many other years, and he was once a host of our society meeting in Nancy, and he is very well known, and also Nancy, for a good wine. So our president, Sally, is still erroneously affiliated on our internet page as a professor at Nancy University, as far as we have a good wine. So, welcome, Olivier, and you are going to talk about the conservative treatment from placenta left in situ to focal resection, because there is not one, the only true, and there are several different options. Please, the stage is yours.
Thanks a lot, Bedouin. First of all, I really want to thank Marilia and Stravos for their organization and their great hospitality. I'm very happy to be there, and it's very sad for me to have to fly back to France, but as usual in France, we have strikes, so I have to get my planes, because if I don't get it, no more planes to go back, and I have to be there tomorrow morning. Bedouin, your French accent is getting better and better with the years. I don't know how you will find my English accent. I always have the honor to talk just after the Irish girl and before the Oxford colleague, so it's not easy for me, but I will try to do my best.
I answer, it is charming, beautiful, and sexy.
Thanks. So we're going to talk about the different options for conservative treatment. Of course, and I thank Dr. Soleimani because he agreed for me to talk just before him. He's going to talk afterwards about the caesarean hysterectomy, which remains the standard for care in many countries in the world. But we are going to discuss why we should have other options, and conservative options are important for placenta acquita treatment. Nancy is not the most well-known city of France, but it's really a wonderful city. I really think you should avoid Paris. Because it's a mess. We have the Olympic Games and all those things. So if you want to visit France this summer, come to Nancy. It's a UNESCO city, very nice in the northeast. It's quite a big hospital. That's why we have to deal with regular placenta acquita spectrum cases, because it's the only tertiary care hospital for a neighborhood of something like more than 20,000 deliveries a year. And all the cases come to Nancy. So what are the surgical goals? Not only be the best surgeon, it's always our goal to be the best surgeon and much better than the other surgeon, but it shouldn't. The surgical goals are for women. So what are our surgical goals? First of all, we should avoid mortality, of course, and even if in developed countries mortality is becoming a rare event, it still occurs, and you will see it occurred quite recently in Paris. Second, we should try to limit the morbidity. Morbidity, of course, is massive bleeding, surgical complications. We're going to discuss that. But you heard Elena in Dublin, and you can see that hysterectomy by itself can be considered as morbidity for at least a part of the woman. Some women really won't matter that much about hysterectomy, but some of them, it's going to be a big problem. So at least for these women, we should have alternative to hysterectomy. Then we're going to discuss some techniques, but I think you've heard the essential points this morning. We don't know what is the best technique. What we know is that you should screen this woman and avoid having an improvisation, discover it at 2 a.m. in a center where you cannot call any colleague, you don't have blood. I think Sally wants perhaps to see. I don't have it. Sally, can you play the video again, please, just for Sally, because she likes it. Let's go. Okay. Yes, you have it. It's in China, it's not in Europe. So we should avoid improvisation in order to have patients treated in expert center with trained surgeons, trained anesthesiologists, resuscitation facilities, and interventional radiology, whatever will be your surgical strategy. And it's the only way to avoid catastrophic situation. As you can see on the right, it's a patient that was transferred after a C-section with the placenta was not as usual, they told us on the phone. We had some difficulties, and they didn't send us the woman because of that. They sent us the woman because there was nothing in the urinary sac. And you can understand why. Are we really in such a situation? Because you've seen experts with ultrasound and MRI this morning, but most of the patients, they don't have these experts. So really, one of the most important messages is send the woman to the expert each time you have the placenta, low-lying, and a previous uterine scar, because we shouldn't have C-sections where you open and you find that. They didn't see it with the Doppler. Here you can see the blood is moving inside this, and you don't need the Doppler for that. In a recent publication from North America, 2019, they had almost 2,000 cases of PASS, and the median number of cases treated per unit was 2, with an intercalcity of 1 to 4. So there was no expertise at all, which is one of our problems if we want to compare the different techniques on a surgical point of view, because most of the published data don't come from expert centers. So it's very complicated to compare. So now let's go to the techniques available. Before I had Donald Trump, now it's Joe Biden, I don't know for how long. The recommended management of suspected placenta accreta spectrum is planned cesarean hysterectomy with the placenta left in situ in North America. And that's really what they do. They don't test, they don't check if the placenta is accreta, they do the cesarean hysterectomy, and then sometimes they have false positive. That's not the only problem. Of course, with hysterectomy, you don't have any more fertility. You have a specific hysterectomy-related post-traumatic stress disorder. You have many surgical complications when the intervention is not performed by my colleague Soleimani, who doesn't have any complication, but you don't have that many people who have the surgical skills that he has. So in the true life, you can see that bladder complications are up to 6 to 29%, heart tears up to 7%, reinterventions up to 30%, median blood loss 3 liters in real life, less with your technique, but it's with your technique, more than 10 liters in 30% of women. And another problem is that you have false positive cases in up to 30% of the patients. So I show you again the video on the right. This is a C-section with a fondal incision. Patient is under general anesthesia around 35-36 weeks, as it's recommended. And then at the end, you get the placenta. This was not for cesarean hysterectomy, but in the States or in Canada, they don't test it, and they have up to 30% of false positive rate of placenta accreta. And they did the hysterectomy. So you have to go after the C-section to see the woman. Hopefully you may have Elena with you, but most often she is not with you. And you say to the woman, okay, good, I've got good news. The cesarean hysterectomy went well. The bad news, you didn't have any accreta. Okay. So what are the other options? one of the options, which is really a French option, so that's why my colleague asked me to present that, even if I don't do that anymore, is to leave the placenta in situ. Why did French people think about leaving the placenta in situ? We all learned obstetrics many years ago, some of you many, many years ago, me middle years ago, with people telling us at the end of the delivery, you must have an empty uterus. Take off the placenta, okay? We know that with placenta aquata spectrum, bleeding occurs in case of rupture of the utero-placental interface. So, as French people like easy thinking, not too complicated philosophy, just say, okay, it bleeds when you touch it, so just don't touch it. Leave it inside and go back home or go to the restaurant, have a good wine at midday, and it's going to be okay. So that was a proposal at the beginning of the year 2000. Placenta in situ offered less hysterectomies, less transfusion, and less coagulation disorders. Fertility is preserved when conservative treatment is successful. We've got a series of pregnancies after placenta left in situ. With the hysterectomy, we had, as usual, high risk of complication, especially in case of Percreta. But we have to take care about these results because these whole results were not compared with controlled cesarean hysterectomy. They were compared with extirpation. At that time, it was extirpation or leave the placenta in situ. And the other problem is that it's very different between different countries. But in France, most of the obstetricians are only obstetricians. They learned surgery when they were young, but they don't practice surgery anymore. So they have very low surgical skills. And of course, if they are alone with a Percreta and a hysterectomy to perform, it's very risky for the woman. Dominique Cabral, you can see on the left, he was the head of Port Royal unit. He was the guy who created this way of thinking, and he was very successful in France because it is still the recommended way to treat placenta aquata. It's from 2014, but the recommendation is to leave the placenta in situ, essentially in case of Percreta, because it's harder to perform the hysterectomy. So, how do we do that? I have to show it to you because it's the theme of the topic today, but I'm not encouraging you to do that. You always have a risk of massive bleeding, so this should be done in referral units. You should be ready for massive transfusion. Women position should allow access to the vagina, not with placental hysterotomy, because the principle is don't touch the placenta and leave it in situ. And you have to adapt the cutaneous and uterine incision in order to be able to have the hysterotomy far from the placenta. So most often it's a median incision. Then you do the hysterotomy. Transversal incision is feasible in case of low-lying or posterior placenta. And sometimes you have to do even a posterior hysterotomy. So we have also false positive. So if this one was a false positive, now she's much more lucky the next time to have a new placenta aquata because you have new scars on the uterus. And then you deliver the baby. The placenta is left inside the uterus after careful verification of absence of cleavage plan. You just give oxytocins and antibiotics. We don't know which antibiotics. It's just we try penicillin or macrolide, but just because the placenta is going to stay there, and sometimes for a month, and then to wait for the placental elimination. What can we do in case of persistent bleeding? So many things have been described. At the time we performed that, uterotonics. We use prostaglandins, intravenous prostaglandins in France. If you were able to tear off at least a part of the placenta, you can use tamponade if the cervix canal is free. You can use also surgical devascularization. You can use pelvic embolization. And at the end, if it's still bleeding, and this is just an image to Freddy there, you can perform a hysterectomy. This is Freddy in Liège performing a hysterectomy. And what about quality of life? Quality of life is just a disaster with placenta left in situ. We have to say that. You get a risk of delayed bleeding until the complete elimination of the placenta. You've got a risk of infection, sometimes 6 months after the placenta left in situ. You've got a risk of hysterectomy, sometimes several months after the placenta left in situ. You have prolonged vaginal discharge, which is very complicated for the quality of life of women. And this is an extreme discharge several months after the placenta was left in situ. What is the acceptability for women? We don't have many data about that, but really it's very poor. Sometimes you have to go back for hysteroscopic resection or re-intervention to take off the placenta. So it's really not a simple journey if you succeeded in leaving the placenta in situ. Another problem is that really it doesn't work all the time. The first reports, as usual in medicine, are always very optimistic regarding what happens really later on. So this is a situation that was one of the last in Nancy. We are quite cool. We were leaving a young senior for the intervention. I'm here on the right, with much less gray hair. And since the incision, we had a massive bleeding at the time of incision. And the big problem with this strategy is that you do not prepare anything for the hysterectomy. So you open the uterus, you didn't touch nothing if it's a perqueta. Everything is there with the bladder, with the neovascularization between the uterus and the bladder. I mean, if it bleeds massively, you have to go to the hysterectomy, which is very dangerous and can lead to catastrophic situation. Whatever, you know that humility is the best quality of French people. It's well known. So the French feeling remains, not my feeling, but I work with Sally, so I learned about humility. Placenta left in situ. Many French people still believe that it performs better than caesarean hysterectomy, and it remains the French guidelines since 2014. And we had even this publication in 2022, which is an observational study, the Paquita study you may have read. And the conclusion is it performs better. But what they forgot to say in this publication, I'm part of the publication, but I couldn't fight with all the authors because it's not possible. I live in France with them. What is not said in this publication is that we don't really know what was the intention to treat. You've got the group with placenta left in situ that succeeded, the group with caesarean hysterectomy. Part of this caesarean hysterectomy were failed placenta left in situ, and they conclude it's better to leave the placenta in situ. So it really has to be discussed. So this was the last time we won the World Cup. Then we had troubles. We had to think a little bit about our strategy. And one of the guys in France, very nice person, it's Louis Marcelin. We work with him sometimes, and he's from Port Royal Hospital in Paris, where this technique was created at the beginning. And I really love them because they are very honest people. They publish data even if the data are not good at all, and the data are really not good. This is his recent publication, 2018, in the American Journal. And as you can see, we recommend to keep the placenta in situ on the uterus, especially in case of perqueta. In case of perqueta, hysterectomy rates because of fail of placenta left in situ, 86%. In the easiest cases, ACRETA 25%, acute maternal morbidity 27 to 86% for severe morbidity, septic shocks, and 2 maternal deaths in the center of Paris, 21st century, with all the means that you can have. So it's not that safe. It's not that simple. What can we do? What can we say if we compare with caesarean hysterectomy? Not simple, because we don't have any direct comparison. It's only cases reported by expert centers. But really, we cannot say that it's better than caesarean hysterectomy in terms of safety for the woman and surgical complication. So, almost finished. We must go now to consider focal resection. And really, it's hard for me to show that because it's the last time when we lost the World Cup against Argentina. But sometimes it was very hard. But sometimes Argentina is right and France is wrong. And we have to go to José. I think you have a better pronunciation than mine for José. But José, yeah. And José was the guy who first proposed uterine conservation, but without leaving the placenta in situ. It's not feasible in all patients. I'm going to show that. But the principle is we have the birth of the baby far from the placenta, and instead of leaving the placenta in situ, just take off the abnormal placenta and close the uterus. So go fast for how it goes. Then the baby was born. We are doing the resection. We started to do that in Nancy at around 2016, something like that. And then you close the uterus. What are the results? Really almost finished. Results are very encouraging. This was published by Jose. Almost in 80% of the cases, you can keep the uterus without placenta in situ using this technique. But as you can see, it really doesn't work very well in the more severe cases, with also a risk of massive bleeding in the more severe cases. Another problem with this technique is that you perform the biggest part of the dissection between the bladder and the uterus after having the baby born. So it's at risk of bleeding at this time, and that's why the success rate is quite low in the most severe cases. Recently, Alvaro, a friend of her from Colombia, published the results of one of the first randomized control trial comparing resection versus hysterectomy. Results are very encouraging. The big problem with randomized control trial is that it's impossible to have it blinded. And here, people who perform the surgery are more trained and convinced by resection than by caesarean hysterectomy. So there may have bias, but this confirms that it is quite safe and at least as safe as caesarean hysterectomy in most of the cases. And after 2016, we started to practice these resections and quite quickly noticed that the big problems was the bleeding after the baby birth. So we had a discussion with anesthesiologists and pediatricians, and they told us, okay, no problem, there's no hurry for having the baby birth, so if you're better to do your dissection before the baby was born, do it. And one of the goals of the anesthesiologists to tell us to do that is that they wanted us to be ready to perform a fast hysterectomy if there was a bleeding after the birth of the baby. So we started to perform the dissection since the beginning, and I will go fast because time is flying. It's quite hard to do. It's the same principle as the resection described by Jose or by Alvaro. You have to start on the lateral sides of the uterus and the bladder because it's easier there with much less vascularization, and then go to the middle, which is the hardest part. And I think Roman is going to show that it's the same when you do a caesarean hysterectomy. And at the end, I don't know if you can see it on the right, there is a vaginal examination, and we just check that we are low enough behind the bladder to be able to perform the hysterectomy very fast. And doing so, we noticed that in most of the cases, it was feasible to keep the uterus, even in very large placenta percretas, because the big difference with José's technique is that they leave the placenta and they do the resection with the placenta. In our technique, we take off the placenta. I'm going to go very fast because we don't have time. We use systematically a tourniquet here, so it's not bleeding anymore when you want to do the resection, and it's much easier to close after having the tourniquet placed there. And it's the end. Just some take-home messages. The most important point remains screening, whatever the technique you choose and the technique you are going to discuss with the patients. With surgical techniques, we have no comparative data at all except the randomized trial, which is quite preliminary results from Alvaro. No clear advantage for a technique or another. Placenta in situ or focal resection are alternatives to caesarean hysterectomy, but really take care with placenta left in situ. It's very complicated for women afterwards. We really need for robust prospective data from expert centers. And as Vedran said, I think that it's of high importance to discuss about what to do with placenta excreta spectrum, but it should be of at least as high importance to discuss about how to prevent placenta excreta spectrum, which is iatrogenic. It's due to a caesarean section rate. It's feasible because in Finland they have had the caesarean section rate quite low for years, so they do that. And in France, we succeeded in maintaining the caesarean section rate at around 20%. So it's really feasible to do that, and we should train, and it should be one of our priorities. Thanks a lot.
I'm very glad to be here, and I'd like to thank Dr. Fotopoulos and Dr. Nicolaidou for inviting me this meeting with so many experts and to deal with this very important aspect of our everyday life in obstetrics. The next speaker is Professor Soleimani Majid, who is a consultant obstetrician and gynecologist and professor and subspecialist in gynecological oncology surgery in Oxford in the United Kingdom, and Professor Soleimani Majid will talk to us about radical nerve sparing hysterectomy.
Thank you very much for a very kind introduction. So, good morning, everyone. It is an absolute pleasure to be here. I have had the luxury of working with the Greek obstetrician gynecologists over the years. I've found them extremely talented, educated, and very knowledgeable. Some of them have been my fellows in recent histories in Oxford. They're now consultant colleagues. Some of them are sitting there. We have worked together before in Oxford. And many, many thanks to our very kind organizers, which have done a fantastic job. We are very grateful to be here. I'm going to take you through to the radical nerve-sparing hysterectomy. This is what me and Sally thought about many, many years ago in Oxford, because we wanted to stop the utilization of urologists and interventional radiologists, because we thought we could bring very safely the gynecological, oncological, surgical skills in the management of severe PAS. I'm talking about a very extreme end of the spectrum which needs radical approach. I have nothing to disclose. We all know that the severe PAS often behaves like a locally invasive malignancy, and that's why we wanted to bring the gynecological skills. Hence, the surgical approach to manage this unique, challenging pathology requires vast and in-depth knowledge of abdominal and pelvic anatomy. Our team, the Oxford team, which we have seen in the previous presentations, have refined and standardized an approach to radical cesarean hysterectomy for severe PAS, which includes a surgical technique extrapolated from the principles of gynecology oncology. As a result, we created a systematic, a stepwise, reproducible, and robust technique for complex peripartum hysterectomy to manage severe PAS. It's available for free on our website, and I'm very glad to see these days we operate with other colleagues in other surgical disciplines, including orthopedic, sarcoma, and vascular team, who are utilizing this website for their own teaching and training. So it applies not only to obstetricians or gynecologists. I think it applies to everyone who is involved in pelvic surgery. Now, the anatomy is the backbone of the psych approach. So I'm a very passionate anatomist. I feel that you cannot do anything without knowing where the vessels are coming from. And I'm very keen to understand where the origins are, because I believe if you close the tap from the origin, you will be able to respond in a proactive fashion rather than a reactive fashion. So you will never do anything in a hurry, and if you have a bloodbath, it's very likely that you will cause injuries to multiple organs. So it's very important then to be fully aware of the anatomy, and we do go to anatomy all the time. We attend dissection courses all the time. We go to look at the cadavers all the time, because I think we all need retraining. It's very similar to what the pilots do in the aviation industry. It doesn't matter who you are, you need to revisit your anatomy all the time. Now, I don't know anyone has had experience to work with the trauma team, but remember, in the trauma surgery, when somebody comes with a road traffic accident, we divide the abdomen and pelvis to 3 zones. Pelvis is considered to be a very difficult zone to get into. The reason we have bleeding is just because if you have injury to aorta or inferior vena cava, it's very easy to cross-clamp those organs because they're readily available. But pelvis is dark, is narrow. Women have different type of pelvises, from android, anthropoid, there are different types of pelvises, and often you find it very difficult to navigate. So zone 3 is where the problem is. And that's why I always believe the pelvic surgery is in the realm of the gynecologists and gyne-oncologists. Now, if I could play this video, which I should be able to. Could you kindly play this video? I'm trying to. Okay, fine. So this is what we do in gyne-oncology. So reaching out to aorta, IVC, is what we do on a regular basis. There's nothing special about what we do. This is our job. So you can see in this video, I think if you dim the theater light, it would make it easier to see the screen, if someone can do that. But you can see on the left-hand side, on the left video, we have done what we call a Mattox maneuver when we mobilize the descending colon from the pelvic brim to the splenic flexure to be able to get to aorta. We do that for gynecology, oncology all the time. And on the right-hand side, you can see the pelvic vasculature is fully skeletonized because we have done a systematic lymph node dissection. Again, it's very routine in gyne-oncology. Again, on this, on the left side, you can see all the branches that you need to be familiar with. This is, again, it's a Mattox maneuver when the surgeon has mobilized the descending colon right to the splenic flexure. That would allow you to get to the aorta. So if you need to clamp the aorta, you will clamp the aorta. And again, we do this routinely. Now, one of the key thing about anatomy is whenever you have a problem, you need to know everything about the proximal and distal to the pathology. So the placenta percreta is sitting in the center of the pelvis. So you have familiarized yourself with the vessels going into it, but what about the vessels which are departing the placenta? It's not unusual for me to get codes to theater when laparoscopic surgeons or other surgical colleagues have injured the external iliac vein, and I see they're trying to clamp the proximal end of the vessel, not knowing the external iliac vein, in fact, used to be, or a few centimeters down, is a common femoral vein. So you need to know what is going into it and what is coming out of it if you want to deal with the bleeding. And that applies to all the pelvic operations we do. With Sally, we created this technique, is 25 steps, because we thought we need to be able to make sure we have a way that everybody could get trained to do it. And we are proud to say that as the time has passed, many colleagues around the world are trying to model themselves through this systematic approach. In fact, I have brought a lot from the placenta service to the gynecology oncology, share with other colleagues. So I'm not going to go through all the steps because they are available on our website, but I'm going to go through some of the key steps. The key thing is the positioning of the patient. This is a modified Lloyd-Davis. Remember, these patients are going to be operated for 3-4 hours. This is like a long-haul flight. They are at the risk of compartment bell leg compartment syndrome and also femoral nerve neuropraxia. We wrote a paper, published it in BJAG, how to avoid this. A lot of other colleagues are using our checklist because it's very important to be mindful of the legs. Remember, we do one of the longest operations in all other surgical disciplines. We do cytoreductive surgery for 6-7 hours. These severe placenta might take 3, 4, 5 hours. So it's very important to go through this checklist on a regular basis. The first, step 6 is abdominal entry. This is our incision. So if I could play this video, this is a sac incision that Sally very intelligently brought to the service because we knew that these women would like to have a transverse incision. So what we normally do, if you could play that video, if I could, apologies for so many videos here. So basically from the anterior superior iliac spine to the right, to the left, you open the abdomen with a transverse incision, then you negotiate your way inside through the midline. So it's like a hybrid incision. From when you look from outside, looks like a transverse incision, but in fact, what we are doing inside is midline laparotomy. Then, of course, we do intrapartum diagnosis primary survey. That's where all the obstetricians, gynecologists get together to do another intraoperatively MDT to make sure we are agreeing on this. This is a severe pass. When we have agreed, once again, this is a right patient to do a radical hysterectomy, then we move on further. Sally then comes in to identify the age of the placenta. We are all very patient, watching, and make sure that we give the patient a right incision. Then, of course, we open the fundus. We do our first hysterotomy with the fundal incision, and we have started using a GIA, either 3.8, 4.8, blue or green, because we wanted to minimize the blood loss even further. So, and it's a very good approach. Now, when the baby is born, placenta is in situ, we close the hysterotomy. Now we prepare ourselves for hysterectomy. So we would never delve into or dive into the uterus because we have agreed intraoperatively this is going to be a severe pass case. So we have to prepare ourselves. And how do we do that? We open the round ligament. We know the round ligament is the gate to the pelvic side wall from the corneal end of the uterus to the internal ring of the inguinal canal. We use LigaSure to divide that. And then, as you can see in this video, the round ligament, which has the Samson artery in pregnancy, is much bigger than all the postmenopausal patients that I treat for cancer. So you have to make sure you identify this and follow this through right to the internal ring, because you want to tie this very lateral. By getting the round ligament as lateral as you can, you will be able to get to the pelvic side wall much easier. So it's not just the round ligament, it's a guide wire to the pelvic side wall. You follow it through, and we use 2 clamps. We use LigaSure Impact, which is our favorite instrument, to divide and tie and keep the tractions. You ask the assistant to keep and pull on these strings to make sure that you have a very nice traction, so then you can negotiate further your way into the pelvic side wall. LigaSure Impact, I don't know how many people use this, but it's a very, very efficient instrument. You can basically remove anything in the abdomen and pelvis. We sometimes joke, we say we could do abdominectomy with this. It's very, very reliable hemostatic energy tool. Then, of course, it would be the pelvic side wall, the black box of the pelvis. So this is not a problem for us. It's a problem for colorectal surgeon, urologist. I see many, many people come to gyne-oncology theater because we routinely, without knowing, get into the pelvic side wall. We were talking about earlier on about neuropelviology. We get to sciatic nerve, we get to obturator nerve, we get to these vessels. This is what we do. There's nothing special about what we do, but that's what we do. So it's very important that we familiarize ourselves with the potential pelvic spaces, something that we brought and extrapolated from the radical hysterectomy for cervical cancer. There are 8 avascular spaces in the pelvis. We try to find them, prepare them, and develop them. As a result, we can get to the key structures. You can see the internal iliac and these structures and spaces you can see during the laparoscopic surgery. And also, we try to do this in a nerve-sparing fashion. It has been a very long time since Hidekazu Kobayashi taught us that there is a nerve called inferior hypogastric nerve, which we need to avoid. We do it at laparoscopy, we do it at laparotomy. And these women go home without having any post-operative voiding dysfunction or post-operative bowel issues because we preserve these nerves very carefully. In fact, if you look for it in obstetric young women, you're able to identify them much better than much older patients. And again, you find the spaces that the ureters are at risk. This is called Yabuki space, which is 2 centimeters lateral to the ureter in the vagina fornix. And then this is a step 16. This is where we identify the ureter. So we stop using the stents. I never understood many years ago why do we need to put the stents, because I realized that urologists always struggle to put the stent because it's a 40 centimeter uterine mass. I thought they were putting the stents to identify the ureter if the ureter comes to harm, but the key was not to cause harm. So what was the glory of having a stent? So very, very routinely we open these spaces. As you can see, this is the roof of the pararectal space. The uterus has a placenta. You medialize the uterus, you open the pararectal space, you find the ureter. This is O'Shaughnessy and Russian. You pass the vessel loop, and then you have the ureter in hand. So when you have a bloodbath, you don't start clamping in a hurry. A lot of these injuries happen because these key structures have not been identified in advance. You sling it and you keep it in hand. If anything happens, you will be able to deal with it. Now, the second step of the operation is the access to the right common iliac artery. So we routinely, for the cases Sally If Sally says, I'm worried today, I get really worried without showing how worried I am, because I'm supposed to be calm, and I do my best to be one, but I would like to be prepared. I'm a surgeon that I will not take chances on anyone's life on the table. I think it's just very silly and it will not look good, so we have to be well prepared. So as you can see, we lift up the common iliac artery with the Russian and with the O'Shaughnessy, which is at the right Leahy or right angle. You negotiate the sling underneath and you bring it up. The reason for that is if she starts bleeding, we know where the common iliac is, and the common iliac artery is completely off the inferior vena cava, and we go with the Fogarty or Satinsky or DeBakey, we just clamp it. It's a very, very simple step of the operation, and it doesn't take us too long before we start the hysterectomy. When the sling is on the common iliac artery, if you have any bleeding, nothing will happen to anyone. We just clamp it, and you can keep the clamp on the common iliac artery for 1 hour, 2 hours. How did I learn that? I used to go with a transplant team when they do simultaneous pancreatic kidney, SPK, we call it pancreatic kidney transplant. And you can see they keep the clamp on the common iliac for an hour, 1.5 hours. And if the trainee is doing the transplant, this could be even more than 2 hours. So there's no fear of clamping these vessels. When that is prepared, we go and identify the internal iliac artery. So this is something that we routinely do for these cases. Common iliac artery has been identified. Internal iliac artery is then well picked up. Remember, your nemesis just below the internal iliac artery is internal iliac vein. In pregnant patients, in young women, these maneuvers are far, far easier than gynae-oncology, because in gynae-oncology we have to operate in the radiotherapy field. Everything is cemented and navigation is difficult. So you have the luxury of having these vessels prominent and very easy to get into, and they're very resilient, so you can just pick them up, and then this is where we pass the tie 3.5 centimeters from the bifurcation. That means we will spare the posterior division, which has 3 branches, iliolumbar, laterosacral, and supragluteal. And then you tie, if you need to. If Sally said, oh, we're going to tie this side, we will tie that side. And then you will have the uterine artery, superior vesical, vaginal, pudendal, and obturator artery all tied off. So whatever goes into the center of the pelvis is completely under control, and what you will be left is a cadaver. This is what happens when I do a splenectomy, for example. You tie the splenic artery, the splenic vein is open, the spleen gets shrunken. It's the same thing happening with the uterine body. You tie the internal iliac or the uterine artery, and the uterus gets smaller and smaller because the uterine vein is open and is emptying into the internal iliac vein. Very simple principle. Sorry. Then, of course, step 18 is securing the tubo-ovarian ligament and ovarian preservation, which we do. And, of course, salpingectomy, going to the previous discussion about sterilization, we tend to, if that plays, doesn't play, apologies. If we do opportunistic salpingectomy, because we know the high-grade serous ovarian cancer arises from the end of the fallopian tube, from a precursor called a stick. So whenever we get the chance, we remove the fallopian tubes. Now, the next step is bladder mobilization. This is the most difficult part of this operation I've learned over the years. Now, if you look at this video, if you look at the back, both right and left common iliac arteries are slung, internal iliacs are tied, and I have time with Sally to mobilize the bladder in a very calm, relaxed fashion. I'm someone, if I want to have a dinner, I would like to have candles on, music on. I can't just dive into the dining table and eat something and run away. It's the same thing with the surgery. When you have everything ready, you will have less morbidity. There is no red carpet waiting out. I mean, I tell all my fellows, do not rush to do the operation, because you do it in a hurry, you have to come back tomorrow for complication, return to theater, collection. It takes you extra 30 minutes just to do it properly. Because the cases we deal with, this is almost like muscle invasive bladder cancer. Do not call the urologist for this. They will run away and they will hate you. They will never come again, because this is not something they are used to. This is a different beast, and it's down to us to fix the problem. But if you are in control and the uterus is going through the ischemic changes, there is nothing to be worried about. Even if you have to open the bladder here, which sometimes we do, we call it a partial cystectomy, but you do never need to do radical cystectomy or remove the entire bladder because you are not in a hurry, and this is a placenta case which otherwise would have bled a lot and you were not in charge. Your Buchwalter, which is my favorite retractor, is on. Now, of course, this is the anterior colpotomy, so we never do subtotal. I've never done subtotal hysterectomy in my life. We always remove the cervix in its entirety. It's very simple because the cervical artery anastomosis with the descending branch of the uterine artery. If you leave the cervix, you go back to theater a few days later to removing the stump, and you don't want to leave the cervix. Women get cervical cancer, small bowel sticks to it, you get a stage 4 cervical cancer. I think it should not be done. But it's also oncologically en bloc removal, and you do it with a swab and a stick in the vagina. It is on our website. And then the vault closure, which is a step 23, we close the vaginal vault with multiple interrupted stitches because if you have collection or hematoma, it will find its way through the vagina, but there's no need to put the drain. If you look at the back, it looks like we have done a radical hysterectomy for cervical cancer. If you're asking me, these operations are far more complex, and we forget to give ourselves a true credit, a real credit we deserve, because we're so humble, we just prepare for the next case. But that's how it should be done. Now, we published the SAC technique in American Journal. These are the preliminary studies, preliminary data about how we managed to show that we don't need to do IR. It was a very difficult task for me and Sally because it was a taboo in England to, in a hospital that the guideline says you have to stent, you have to do IR, we had to come up with something which is reasonable and in a very humble fashion gradually push our agenda. Now, this approach, we believe, precludes the need for preoperative stenting, thereby decreasing the risk of accidental trauma to the ureter and other adverse consequences such as bladder trauma and infection without the increased theater time required for ureteric stenting. It respects and spares the pelvic autonomic nerve plexus, should also avoid bladder, bowel and the bladder dysfunction. Use of a transverse incision is not more cosmetically pleasing for women, but also reduces the risk of wound dehiscence and incisional hernia. We believe the SAC is systematic. I think it works really well because we follow the steps all the time. It is a stepwise and it is reproducible, and it allows us to develop retroperitoneal avascular pelvic spaces to ensure we could see the pelvic vasculature, autonomic system, nervous system, and also the other key structures. And it allows you to have a direct control of the pelvis, which would decrease the risk of catastrophic hemorrhage in these women. And SAC has led to reduced blood loss, and also the morbidity is going down. I'll leave that. Thank you very much.
Okay, our next, I have the pleasure to introduce the next speaker, who is Dr. Stavros Fotopoulos, an obstetrician gynecologist, head of delivery operating rooms in EASO Hospital here, and head of the unit of facing PAS in EASO. He is also a scientific collaborator of the third obstetrics and gynecologist department in the University of Athens. He's probably the most expert in this field in our country, and a long-time friend. So I'm very keen to hear what he's going to say on the surgical treatment of us, a single-center experience with multidisciplinary team. Please, Stavros.
Thank you. Ladies and gentlemen, dear colleagues, I would like to thank the President of the ISPAS, Sally Collins, and the board for organizing this scientific meeting. During the next 20 minutes, I will speak about the surgical treatment of dozen cases of PAS, treated in the Center of Specialized Treatment for PAS in EASO Maternity Hospital from 2018 until today. The first case of PAS was described by Alexandrov. In our days, most cases are found among women who have had a cesarean section in past. starting from Irving and Herding in 1937, who described 20 cases of PASS in their paper in 1937. We have now reached an integrated system of PASS from Collins and al. In 2015 and in FIGO classification in 2018. FIGO classification, grade 1, grade 2, grade 3, and subdivisions. Where should we treat these cases? The specific criteria are well established since 2015, as you can see in the slide. A multidisciplinary team is necessary, as well as the intensive care unit. However, we believe that Cell Saver is the most important step in the management of PASS cases, in combination with the thromboelastography. When should we deliver these cases? One recommendation is for delivery between 34th and 36 weeks gestation, while FIGO recommends delivery between 35th to 37 weeks of pregnancy. However, half of PASS cases never reach the 34 weeks, according to our experience, and as well Palacios' experience, Jose Palacios. Which way should we operate the PASS cases? That means which will be our surgical strategy. The surgical strategy will be planned based on specific surgical findings, like do we see neovascularization? Is there invasion of bladder or parametrium? Which are the possible surgical problems that the surgeon may confront with? One may the newly neovascularization in the pelvis. Another, the possible injury of the bladder or the urethra during the operation. So, when we operate a PASS emergency case, the surgeon should have in mind practical tips. Is there placenta tissue in parametrium? Are there annually formed vessels? In order to evaluate these spaces, the surgeon should dissect the broad ligament and get access to the corbouterine and the retrouterine spaces. The severity of the case depends on the placenta topography. When a placenta is found in S2 area, hysterectomy is more probable scenario. Although, before operation we have information about placenta topography, the final estimation is made by the surgeon in the operation room. Many times, the surgical problems we have to deal with during PASS operation result in complications, as we can see in this table from the FIGO guidelines. The major problem remains, in all cases, the massive blood loss. In 2018, FIGO has published guidelines concerning the conservative management. The expectative technique, removing the placenta manually in an attempt to empty the uterus at delivery. The expectant approach, previous speaker, leaving the placenta in situ and waiting for the complete spontaneous resorption. The one-step conservative surgery from Jose Palacios, pioneer. The triple P procedure avoids incising through the vascular placenta venous sinuses and excise the myometrium with the PASS disorder tissue and to constitute the uterine defect. One of the technique or combination. Applied also in combination with the interventional radiology procedures. It is well known that in past cases, hysterectomy is not the only option anymore. However, we should know that the PASS hysterectomy is not just another hysterectomy. Special preparation and skills are needed from the team, which should be trained to deal with the many different scenarios in the surgical field. Even in past cases, the only real reason for hysterectomy is the uncontrolled bleeding. We should not forget that any trial of conservative methods in PASS must stop when the woman is hemodynamically unstable. In the most severe case of PAS, we should keep in mind that we may have to borrow techniques and methods from classical traumatology. In case that we have to operate without any preparation, emergency, or even diagnosis before the delivery, the term damage control surgery refers to the methods we can use to control the bleeding instead of doing things that may increase the danger for the patient. This is the way we use a damage control protocol in cases of major obstetric hemorrhage. As we can see, the first step, the evaluation of the hemodynamic parameters and the initiation of the correction of acidosis and the coagulopathy. Next, we proceed the hysterectomy and we close temporarily the abdomen with the packing. After that, we send the patient to intensive care unit for stabilization. And finally, reoperate with removal of packing and the final closure. This is our experience. Until now, we have about 138 cases at the end of the 2023. We have not hysterectomy in grade, past grade 1 and 2. We have in Precreta about hysterectomy about 43%. Turning point is the cell saver. I think that cell saver is help us to surgery without stress. We have blood. Conservative surgery approach for placenta and creta spectrum. Fan sterilization or modify. This is approach and the surgical steps we use in past cases for uterine sparing. This approach is applied in all past grades, all grades. Fan sterilization or modify. Transverse high uterine incision at the upper border of the placenta without cutting through the placenta. Delivery of the fetus. The uterus is exteriorized. Vascular disconnection of newly formed feeder vessels and the separation of invaded uterine tissues from invaded vesical tissues using diathermy and now rarely RF. Resection of all invaded myometrial tissue and the entire placenta in one piece with previous local vascular control. Surgical procedures for hemostasis. Myometrial reconstruction in 2 points, 2 plans. Compression suggests only through the anterior or the posterior wall. Don't join posterior and anterior wall. There is problem with Asherman syndrome. Placement of Bakri balloon. Method of sandwich. Bladder repair if necessary. Uterotonic drugs. And now, in the main differences of our approach from citing conservative techniques. Uterotonics after delivery of the fetus. We use uterotonics after reconstruction of the uterus and the end of the operation. Embolization or placement of arterial segment balloon to assess blood flow from the max supply to grab the uterus. In this hospital, we don't use embolization or place a balloon in arterial. Methotrexate, I think that nobody uses. Midline vertical skin incision or low vertical. We use always low transverse skin incision. Or modify Fanastel. Using uterine stapler or Smith-Orbitz clamp. We don't use. Intentional cystotomy and the excision of bladder invasion. never intentional. If bladder open, then will be suture. Vessel sealing device we use rarely. Total or subtotal hysterectomy. Over 90-80% of cases total hysterectomy. Rarely some total hysterectomy. Oh, sorry. Uterine devascularization. Use of intraoperative cell salvage occasionally in past cases. I think that it is very significant. Over 95% of our cases, almost always we use self-saver. Routine use of cystostomy and the placement of ureteric stents before operation. We never use preoperatively, never. Only intraoperatively if there is invasion of the ureteric trigon and there is problem with the ureter for kicking ureter. Ultrasound intraoperative for assessment of the placenta ends. Never ultrasound intraoperative for assessment of placenta ends. Optimal maternal position lithotomy or straight ledge. Always lithotomy. Internal iliac artery ligation. In past cases, never. Never. Internal iliac artery ligation only in atony of the uterus. Uterine devascularization and preservation of uterus, sometimes. Billing sutures. In past cases, never. Only two sutures at the uterine sandwich. Uterine tamponade with Bakri balloon or three-way silicone catheter. Pelvic or vaginal tamponade, sometimes. Vesico-uterine fibrosis evaluation, not necessary. No vascularization. In fibrotic tissue, not need. Caesarean hysterectomy is considered the gold standard for past cases. In our approach, 0 in grade 1 and 2, and 43 in grade 3 per creta. In heterogeneous mortality, estimate 1 to 7%. Our approach, 0 mortality until now. Bladder dissection before delivery. Bladder dissection always after the delivery of the fetus. Vascular control is handmade, sometimes. Use of methylene blue for checking the bladder. We never use blue methylene. We use normal saline. No. Rarely use of Rotem in past cases, often used. Ureter jelly up to 18%, bowel 2 to 4%, reoperation 18%. Our approach, 0 ureter at bowel. Reoperation 1 to 138. Now, uterus preservation with focal resection in past grade. We think grade 3B. 38 years old woman in previous cesarean section after IVF, twins in 2020. IVF pregnancy, complete previa is second trimester ultrasound. MRI in 30 week. Signs indicate of past grade 3B. Cesarean section in about 32 plus 5 days due to vaginal bleeding. Weight 2,030 grams to 20 and 30 grams. Abaca score 9. Transfusion from cell saver. Transfusion after the video. Transfusion 2,000 669 plus 4 units red. MRI before surgery. Video, oh no, ultrasound. 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 Ultrasound before surgery. And the video operation. No. Το μη φάνεστε. Το φως κλούς. Cell saver. The first side. Delivery with obstetric maneuvers. After exteriorization of the uterus. Compression sensors behind posterior wall of the uterus. Continues with compression sensors. Without uterotonics. Placing tourniquet at the lower part of the uterus, using a Foley catheter for restriction of bleeding. Continues with the compression sensors. Placenta. Dissecting the vesicouterine fold, the bladder is gently pushed away down. Invasion of the bladder. Real invasion. We see the entire placenta attached to the bladder. A small part of the placenta tissue is left on the posterior wall of the bladder. We have two incisions, one upper and one for delivering the placenta. Two incisions. Reconstruction of the anterior wall of the uterus. Laser the second incision. We continue the closing incision. The opening, removing the placenta. Closing the upper incision. We can see tabone. No. We can see Bakri balloon. Yes. Result at the end of the operation photo. Two incisions. One transverse and the other longitan. About 2 liters blood collect from cell saver. Post-treatment MRI. Ultrasound post-treatment 6 months. Uterus after 6 months. Uterus. Thank you.
Okay, thank you, Stavros, and for the talk and for the impressive videos.
Once again, thank you very much to Stavros and Mariela for all the organization, and we'll still have some fun this evening, isn't it?
Yes, okay.
So now you are going to present us the interpreted self-salvage in your PIS cases, and let's see what are your experience. Here you are.
So, first of all, I would like to thank once again Professor Sally Collins and friend, also our friend veteran, and all our friends, our new friends, ISPAS members for being with us and help us to organize this very fruitful scientific meeting. Yesterday and today, of course. And I am always the last speaker of the session. I don't know how I do that. Anyway, I'm going to talk to you about ICS in past cases. This is something that we are very proud of, I can say. A little bit of us. This is EASO. I just added this morning this picture. Since yesterday we had this beautiful around the Acropolis Museum, so I thought that it would be a nice connection to it. So EASO comes from the Greek word iasis, which means healing. So, the population of Greece is about 10 million, and as I have already told you last 2 days, unfortunately our deliveries are falling, and they are about 72,000 last year, 2023. EASO, however, has the 11,000 deliveries from all around the world. That makes us the first maternity hospital, so we have many deliveries. And we know all that obstetrics is a bloody business, and that's why we are all here today, actually. And unfortunately, although we have so much technology and so much knowledge, even today, according to WHO, about 70,000 women have lost their lives due to PPH. And this is really not a bad thing to happen, since, again, according to WHO, most of these cases and deaths could be avoided. So it's very important for us to get informed and to get further. And as we all know, there are two actually cases that we have PPH in obstetrics. This is uterine atony and PAS cases, which unfortunately are getting increased. PAS is here, and unfortunately is going to be with us for many years unless we do something about the C-section epidemic. And unfortunately for us, here in Greece we lead the way together with Turkey and Cyprus. We have an extremely high percentage of C-sections. Unfortunately, here in Greece we don't have so much we're not so good in keeping the statistics, but we know that we're actually above 55%. And this is also for public as well as for private hospitals. So we have a real problem. And this is also the reason that we have an increased incidence of PAS in our country during the last decade. And I like very much to speak also when I have to speak in Greek meetings, scientific meetings, about this strategy. And this is a strategy that we have incorporated actually during the last years here in our department, because the patient blood management is something that we should do, since the patients nowadays, they want to get informed, and we have to deal with women that they are getting too close to die. We have to deal with the women that they may leave hospital with having much morbidities. So it's their right to know how we're going to use their blood, and it's their right to know that we here in EASO we have the opportunity to use their own blood, and this is something that for surely they appreciate. So, during the last 4 years, we have incorporated, as I told you, this strategy. And as you understand, this is the field. Past cases is the appropriate field to have this kind of strategy, since this is the cases that we have PPH as well as massive transfusion. And actually, the use of cell salvage serves completely the third pillar of this strategy, the avoidance of unnecessary transfusion and the retransfusion of the patient's blood. So I'm going to say a little bit about ICS. So, first of all, the idea of transfusion PPAs goes back in 1888, but the first ICS machine was created in Mayo Clinic in 1968. The key point, however, was the incorporation of the leukocyte depletion filters that we have to do that when we use ICS in PPH cases, because ICS, as you may know, have been used greatly in cardiovascular and in other kind of surgeries. So when we had the idea to use it also for PPH, we had to do something about the possible threats. So, the intraoperative cell salvage is a technique for the collection, processing, and washing and retransfusion of the blood of the patient. It's very beneficial since it has many advantages, this kind of product that we're taking for this machine. As like the elevated hematocrit, the ICS products has a really elevated hematocrit. It's about 55 to 60%, while the unit that we transfuse the women, the heterologous transfusion, it's about 40. Also, the red cells are younger, they have a longer life, and there is also in them increased 2.3 DPG, which actually means that they have the ability to transfer faster the oxygen to the tissues. Of course, it's immediately transfused, and also we have the ability to have this procedure I'm going to show you in next slide of washing lost blood. However, we should keep in mind that having these ICS products, we don't have in that clotting factors or platelets. So the most possible scenario is that we have to transfuse with FFP our patients in order to eliminate any other problems. So, red cells are salvaged from swabs, and we are gently washing them in a solution of normal saline. And we do that because we know that 30 to 50% of the blood loss is actually going to swabs. So we don't want to lose this blood, and so we have this kind of procedure at the end of the ICS procedure in order to collect also this blood. Now, about obstetrics and past cases. Many scientific associations, as well as the anesthetic association that you see here, are strongly encourage and recommend the use of ICS in case that there is a prediction of blood loss more than 500 ml. So, past cases are obviously included in that. And furthermore, in the same publication that I have shown you before, the anesthetics recommends the 24/7 availability of ICS machine in any hospital where blood loss is a potential complication. So that means that hospitals like EASO, that we have to deal with so many deliveries and so many past cases, is a place that we should have, and we do have ICS. Indication of ICS, you can see here, increased risk of bleeding, laparotomy after or due to PPH, of course, patients that they have multiple antibodies and difficulty with cross-matching, and of course, patients with objections to receive allogenic blood, and we can cover also them. The benefits are obvious, I think. We can avoid the usual risk of conventional donor blood, or as infection, incompatibility, reaction, hypothermia, cost, of course. Cell-saved blood has improved survival and oxygen carrying ability compared to banked blood. And for us, another thing that we really like is that we can have an exact estimation of blood loss during our operation. And there are absolute contraindications, as, for example, the clotting agents. If you have this in surgical field, we don't use ICS, or contaminants like urine, bowel contents, or in cases of chorioamnionitis or meconium. And of course, if we have a patient that she doesn't want to use in her operation ICS. However, the main concerns yet today about the use of ICS is some theoretical risks of ICS, as well as amniotic fluid embolism and sensitization to fetal red cells, for which I'm going to speak for the next few minutes. We're all familiar with the AEFE symptomatology, and I hope most of you to be familiar only due publications, because this is actually a very, very bad situation for an obstetrician to deal with. So you see here all those symptoms, which actually, according to the National Amniotic Fluid Embolus Registry, seems to be more like symptoms from anaphylaxis than to embolism. So the term anaphylactoid syndrome of pregnancy have been suggested because fetal tissue or amniotic fluid components are not universally found, as I'm going to show you in next slides, in women who present with signs and symptoms of AFE. On the other hand, it seems that fetal squamous cells, which were supposed to be the gold standard for AFE diagnosis, are almost always, or in most of the cases, present in the blood of women that they didn't have any problem during the delivery. But even if we assume that these cells from amniotic fluid could really obstruct the maternal lung, studies have undoubtedly proved that even if all the amniotic fluid, with a magical way, was transferred to maternal blood, the squamous cells would only obstruct 1 out of 1 million pulmonary capillaries. So, actually, there would be no clinically symptom obstruction or something bad for this, in this case even. But apart from all those things, the use of leukodepletion filters in this machine has also shown to be a significant reduction in contamination from amniotic fluid. So I think there is no possibility someone believe yet that there is a problem about that. However, aluminization is the second topic of discussion about the use of ICS. And actually, we have the problem with rhesus factor because the ABO system is not well organized when the fetus is delivered, so there is not going to be any problem with that. So, about the aluminization, which is the second topic of discussion, as I told you, it seems that the admission of anti-day immunoglobulins solves this problem, and so the hesitation should not be here anymore. And there are specific recommendations about the dose and how would administer this immunoglobulin conserving ICS use. So it seems that 1,500 units immediately after the procedure should cover all the theoretical risks for these women. Now, let's have some literature about ICS. First, about safety. If we have a look in literature, you will find actually no cases of adverse events. So it seems that it's quite safe. In this publication also, there is a comparison between the maternal blood and the blood we transfuse from ICS, and refers that actually all the potential factors that may cause AFE are totally removed by the filters. A review of publication also saying that the potential risk of cell salvage in the obstetric population is parallel to the risk of the general population. And of course, in many recent publications, as the one that you see here, is a meta-analysis of 5 randomized control trials with 3,000 women, 300 women, have reported that apart from the obvious advantages of avoiding allogenic transfusion, ICS revealed no reaction, no cases of amniotic fluid embolism, and no increase of length of hospital staying. But as health economics is a major concern in modern health system, let's see, is it cost effective? Salvo study in 2017, this is a multi-center randomized study, showed that ICS is not really cost-effective when we use it in routine use. So that means that it's not cost-effective if we have it and we use it in all the C-sections that we have planned. However, there are other studies that they prove that it's cost-effective, but only for high-risk cases. That means that in past cases, it is cost-effective to have ICS in your unit. Same here. And now I'm going to share with you a little of our experience using intraoperative cell salvage. As I told you, as Dr. Fotopoulos told you, we have put it in our clinical practice from 2018. And this is a figure that says actually how we have the patient collection for this kind of ICS function. So we have the ultrasound findings, we have the history of the lady, so that rings a bell actually of is it a pass? And here, as you heard from Professor Bouriotti, we have the ability and the opportunity to have between 28th and 32nd week of pregnancy an MRI. So there are specific signs in ultrasound as well as in MRI that shows us that we have a high-risk past case. A past case that we may have an extremely high blood loss, and so this is tell us how to get ready for it. So we get prepared, and if we have a case like that, we should have our intraoperative cell salvage machine. This is the machine that we use. We use it, as I told you, since that was a mistake, March 2018. When we have the need for immediately massive transfusion for PAS, with signs indicated from ultrasound and MRI. We have the availability of it 24/7. We have it here in our hospital, and we have always on call 2 experienced technicians. There are 2 because, as you understand, it cannot be only one. So those technicians are very well trained in using this machine because before us, they have been trained also in cardiovascular surgery. So they are very well educated and they know exactly how to use it and to have the product that we should have. We use it from the beginning of the operation. We have the low pressure suction in order to collect the blood we lost from the surgical field. And this is very important because the suction should be special. It shouldn't be the usual suction we have in the surgery room, because if we use the usual one, then we have lost a lot amount of red blood cells since they are destroyed. So this is a special suction that we use. The transfusion, as I told you, can be immediately. And we do the swab washing that I told you before. Those are our results. More than 50% of the transfused blood is from ICS, and this is translated as faster transfusion and not waiting for the lab to answer the phone, the nurse, to bring us the red blood cell units, and especially in emergency case, this is really life-saving many times. What about safety? All our patients had an uneventful post-operative course, and there were no complications related to transfusion and ICS. And now about the cost, some things I would like to say. This is the only publication that I have managed to find about blood collection in Greece. And you see that in Greece, the production of 1 blood unit costs 130 euros, but until this unit get to be transfused to the woman, the total transfusion cost raises to 500 units. 500 euros. So imagine that each unit of red blood cell in Greece costs that amount in health system. Not exactly the same in the UK. This is a publication that I found from Liverpool Women's Hospital. And they're trying also to see if it's cost effective. And as you see, it seems that the collection and processing per patient for ICS is about 65, not euros, pounds, thank you. While 1 unit of allogenic blood costs 147 pounds. So it's also better in UK. And I'm finishing with 2 cases. So this is hysterectomy, and this is the result of our ICS. You see that 2/3 of the transfused blood comes from ICS. This is very important. And this is a case of uterine preservation. And this is the amount of blood. So, take-home message, cost-effective in past cases, safe with no complication, lower cost comparing to heterologous transfusion, and due to immediate transfusion, we have safer operation for the patient and higher percentage of uterine preservation. It seems to help us since we have introduced the use of ICS, we have elevated our percentages of keeping the uterus. So, we have to work all together in order to save mothers and stop PPH. And as Sally said in the morning, it's not one way, it's the way that fits better to every system and to every patient. And so, I would like to thank you very much. And this is my final slide. This is Athens.